Hello, everyone. Welcome to another ASG podcast to discuss a recent technology review from the ASG Technology Committee. My name is Ryan Law, the current ASG Technology Committee Chair, and I'm joined today by Koushik K from Washington University in St. Louis and Julie Yang from Maimonides in New York. The Technology Committee provides reviews of existing, new, or emerging endoscopic technologies and techniques that have an impact on the practice of endoscopy. These technology reviews are evidence-based methods using Medline literature search to identify pertinent clinical studies on the topic and the manufacturer and user facility device experience database search to identify the reported adverse events of any given technology. Both are supplemented by accessing related articles within PubMed, as well as scrutinizing pertinent references cited by the identified studies. We use controlled clinical trials as best we can, but in many cases, data from randomized trials are lacking. In those cases, large case series, preliminary clinical studies, and expert opinions are used in replacement. Technical data is then gathered from traditional and web-based publications, proprietary publications, and informal communications with pertinent vendors to produce a technology status evaluation report, which is then drafted by one or two members of the ASG Technology Committee and then reviewed and edited by the entire committee prior to publication. Today, we are going to discuss an upcoming publication, which will be officially published in GIE in the coming months. This is an update of a 2011 document on enteral stents. Both Drs. Yang and Das have updated the document to current standards, and it will be available for review in the coming months. Welcome, Dr. Yang and Dr. Das, to the podcast. Thank you for joining.
Thank you for having us. Thank you for the ASG for this opportunity to talk about this document that we updated.
Thanks, Ryan.
So let's start kind of with the most basic question. We'll start with you, Koushik. Why do you believe that the Tech Committee decided to create or in this case update this review at this point? Why was it important to do so, in your opinion?
Yeah, I mean, certainly there's certain parts of our field that have been completely static, and certain parts of our field that are completely new. Since 2011, when the last time this document was there, I think that the stent world has had some iterative improvement, and over the last decade or so in esophageal, enteral, and certainly colonic stenting. I will kind of advise the readers that LAMS in its many kind of forms, including gastroenterostomy and others, have been reviewed in separate tech documents that have been published in the last couple of years. So we won't be talking about that, though obviously that's a major part of all of our practices at this point. But in 2011, we were still in an era where people were still using polyflex stents, in the esophagus, not infrequently. And now, I think if you asked a fellow what a polyflex stent is, they couldn't, spell polyflex stent. And so, I think we've seen, the dismissing of certain technologies like that, in favor of, essentially uniform self-expanding metal stents. We've seen a convergence in terms of deployment mechanisms, as well as an emergence of through the scope deployments, both for esophageal and duodenal stents, and that has really improved access and usability to the point where at the when I was a part of the postgrad course a year or two ago, one of the general GI guys was arguing that fully covered esophageal through the scope esophageal stent placement should be in the armamentarium of a general GI endoscopist for the management of a variceal hemorrhage. I think that we've come a long way from where we were in 2011 in terms of how these things are utilized and deployed.
I agree. Julie, when you think of this document, you've put a extreme amount of effort into making this an exceptional document. Who do you think is the intended audience? Do you see this as just for therapeutic endoscopists, for everybody, for trainees? Who do you think can benefit from this, and why?
I think this document is really for all of us as gastroenterologists, luminal gastroenterologists who deal with these issues of either malignant obstruction or benign indications throughout the gastrointestinal tract. And I think what we really highlighted in this paper is that could be really practicable for everybody is that we divide it into sections of the body, go over the data and efficacy, also safety data. But really, from a practical standpoint, there's a nice table that has listed all the new stents. And again, like as Koushik mentioned, the TTS stents that weren't available in the last document are all there. So it's a nice grab too for anyone who's in the endoscopy unit, whether it's a trainee, somebody who's been doing this for 10 years or even their entire career, little details they might not remember that they can easily pull up on this document. So we wanted to make it very user-friendly for all of our membership.
Great. So, a slight digression into like just the clinical world as opposed to just talking about the document. I personally think that the growth into the through the scope delivery systems has been underappreciated in the field. I think that, you know, the TTS stents now essentially available by most major manufacturers, or at least several. Provides so much more flexibility into how you can manage or treat patients or deploy stents. And as Koushik mentioned, looking at the days of like the Polyflex stent or the Ultraflex stent that had like a very completely different deployment mechanism. Um, I would be interested to know in both of your guys' thoughts on what you think of the TTS stents, because I think it's changed how I do a lot of things as it relates to stenting, both in terms of ease and technique. But I would be interested to hear your guys' thoughts.
I think that you're totally right. It definitely lowers the bar in terms of in terms of bringing more people into the practice of this space, because I think where people had seen it as being a side by side deployment or something that was absolutely necessitating fluoroscopy, that kind of kept certain people out of the door, certain units out of the door, and may not be available in certain situations. And so I think that has definitely improved. And exactly like I was alluding to earlier, the convergence of how of the technology and in the methodology kind of helps, in standardizing how you kind of approach these things. There's still, fundamental principles, and I'll also have a shout out to our sister committee, the education committee, that has a really good training program for trainees who might be watching this, in terms of a core curriculum, in terms of stent deployment that they should take a look at, because all those principles of foreshortening and image guidance fully apply here. There are some unique aspects and features that the TTS stents, still have some, issues with. For example, as I was alluding to earlier, in terms of bleeding management, because of how they're constrained, at least in the esophageal world, for example, you don't get a 23 millimeter diameter, through the scope stent. And so if you're putting a stent in for the purpose of tamponading bleeding and you want a maximum, diameter stent, that is something that you may have an issue with. Similarly, if in certain situations you want a anti-migration fin because you believe that is particularly helpful. And I'd written a paper a couple of years ago, on looking at that versus Ultraflex versus fully covered Wallflex stents. That still is not something that has been kind of brought into the fray of through the scope deployment. But especially if you're dealing with sick patients or people who have trying to deal with a leak or a fistula in a person in the ICU or something like that. My God, it's so much easier to deal with this than trying to bring in a C arm and sort it out otherwise, for sure, for sure.
Julie, what are your thoughts?
Yeah, I mean, I sort of piggyback on that. I think just the ease of it. And again, better visibility because you don't have to do side by side with the scope. And that's great for just practicality of the patient. So you don't have to spend as much time, I think. And also for teaching purposes, it's just a lot more of a one-to-one. So I think it's more understandable and sort of what we touched upon, that it's not so frightening when you have something that you can pass through the channel that most gastroenterologists are very familiar with. So I think it does, TTS really opened the door and made it stenting a lot more possible for more people.
Yeah, I've even found myself in certain cases, and I'm not necessarily recommending for or against this approach, but where I don't even use a wire. I just do it endoscopically with fluoro. Um, and can kind of get things where I want them to be. Now, obviously, precision still comes into play in many of these cases, but it's to Koshik's original point. It's incredible how far we've come from the days of like taping paper clips on patients, their chest to make sure that we put the stent exactly where we want it, to now doing it with wireless technique with just purely endoscopic visualization. So um, I think that's a huge thing, and like I said, I think it's underrepresented or underappreciated for sure. What what do you guys see as, Julie, you mentioned that the one of the main benefits of the paper is not only the content in Word format, but the kind of easy access to the table. Any other things that you would like our viewers or readers to kind of specifically hone in on as a highlight of the paper or a major benefit of the paper in your mind?
I think it's like most documents that the ASG provides. It's just quick and readily available for when you need it when you're in a pinch. Um, and it's nice because, the details when you're there for specific reasons and indications that you need it, or sometimes anatomy you may not have thought about, may make you want to pick or change your mind about the approach or the device that you choose. And so I think that's sort of the practicality that I wanted to highlight about this paper. But again, just the way that we divided it into sections of the anatomy, so that whatever you're dealing with, whether it's a lower or an upper indication, you can just quickly run to that section of the paper that may be pertinent to you in that case.
I think another thing, Ryan, is that we tried to do we tried to talk about the labeled indication for when we are actually supposed to utilize these stents, which almost without exception is in malignant obstruction, and then also tried to talk a little bit about the non-indicated or the not the
Off-label.
non-approved off-label use, which is oftentimes in in benign disease, and in the management of fistulas and perforations and things like that, and tried to kind of make it very clear to people, what is actually, is actually on the box, and what is it that people are actually doing. I think another thing that was, not necessarily eye-opening to me, but I think is will be important for the readers to recognize is that, as with a lot of our endoscopic practice, the quality of the data that we have, really is not incredibly, robust for a lot of these things. It certainly provides that data for safety and efficacy, but in terms of, how robust this is, it's a little bit, it's a little bit wanting. And so, for example, the colonic stent world is a great example of this. And I use the three RCTs that we have from that world as, when I talk to fellows about, endoscopic data, right? We have a first RCT that comes out of Asia that says these things are totally amazing. And then you have two more RCTs that were stopped early, either because of harm or lack of efficacy, and then you have no further data, no more comment for the next 10 years, and we just keep using this device.
Mhm. Yeah.
And that's essentially where we're at in the colonic stent world, right? And I think that that's an important thing, that because we counsel our patients based on essentially those very small randomized controlled trials and some retrospective studies that have inherent flaws in them, and so we try to go over that with them. He's like, hopefully, especially when it comes to issues of malignant bowel obstruction, these patients are very vulnerable when we're interacting with them, and their lifespans oftentimes are extraordinarily limited. And so it's very important for us to keep that in mind and make sure that our palliation is appropriate for the life expectancy and appropriate for the scenario, and that they're well counseled on the risks of this, because the risks, while perforation is problematic to say the least in most patients, it could be completely catastrophic in these patients. And so knowing this data and being very facile with it, I think is important for the endoscopist, at the bedside.
Yeah, I agree, and I think thankfully, I don't think we see a ton of perforations as it relates to enteral stenting in terms of a cause, but in some ways that makes our trainees or people early in their career a bit naive to the fact that it can happen. And sometimes when it does happen, it can be bad. I mean, like you said, catastrophic or a really big perforation. I also enjoy the fact that you guys went in to the off-label indications. and fully acknowledge that it's off labeled and labeled, and it's split out so the reader can recognize that. But the important point in kind of the 10,000 foot view is that this is practice. This is like real practice. So yes, it may not be labeled, but it doesn't mean that us as gastroenterologists or endoscopists should be scared to use these things off label, because they can be extraordinarily powerful in certain circumstances. It's just awareness and the data behind it. And like I said, that's real practice for us. So I think that's important that we included that. Now, in wrapping things up or kind of coming to the end of this, now that you guys are experts in enteral stenting and have kind of done a deep dive, what do you see as the next 10 years? What do you see as areas where we still have gaps? I agree with you, data is one thing, but unfortunately that plagues us throughout a lot of therapeutic endoscopy as high quality data. But I'd like to know what both of you think in terms of where we go from here. If stenting, we do it less in the future, more in the future, how we can do it better, anything you want to kind of pontificate on.
Julie, I'll let you take a swing.
Yeah, I think it's still a really great option in the malignant setting, because as we talked about with the evolution of the TTS, and so it's not as daunting to place, deploy, etc. I think what we want to know in the next 10 years are expanding out to that, and sort of what we talked about a little bit with the off-label use, benign indications. Can we get better at it? And part of that parlays with one of the problems with SEMS, which is migration, which we talk about obviously in the paper, because that's really the plague of it when we're talking about non-malignant indications. And what's new in the paper is all we, briefly touch upon as what we know about stent fixation options, which weren't there in 2011. So something I think we're going to probably see more of, and we'd like to see more studies about that. So I think that's where it's going to go in the next 10 years.
We'll
I think,
probably also have more options for stent fixation, perhaps easier or better. That's also, I'm glad you brought that up, because I actually think that's another highlight of this paper that's certainly additive over the last decade. Koushik, what would you like to add in terms of, future,
yeah.
where we can improve?
I think trying to integrate a little bit more in the world of therapeutics into stents, be it local drug delivery, chemotherapy, radiation, in the context of malignant strictures or antifibrotics in the case of benign strictures, is something that would kind of help move the needle there. I think where we've seen like an initial very significant excitement for the use of these in benign strictures, but it's very funny that whether you stent it with this or you stent it with a SEMS, you look at the basic same data of like a third of them do fine, two-thirds of them don't do fine, and a third of them have some clear complication that makes you wish that you didn't do this. And so it's kind of getting to the biology, the underlying biology of what you're dealing with in this situation is probably not something that you're going to, win. I do think it's kind of exciting as much as like Endovac makes all of us shudder. The idea that they've integrated, or starting to integrate in some formats, these stents with Endovac or vacuum therapy is actually a very exciting, promising thing, addressing both the maintenance of patency, but then also the biological issue that you're dealing with, in fixing a hole. And if they can make that a little bit more user friendly, I think that would be, something that more of us would be excited about getting into. And the final thing is, I think we have all, ERCP skill ends up being at the core of actually getting a guide wire around a stricture, right? So the part of the reason we were talking about the democratization of TTS stenting, but the reason why you can place a stent across a duodenal stricture or a colon stricture or through like a complex fistula is because you're familiar with a guide wire that wasn't designed for this purpose, a balloon tip catheter that wasn't designed for this purpose, a old school long wire tome that is rotatable that hasn't been changed in 15 years that you are like MacGyvering into this practice. And so the fact that we have not seen any kind of innovation in that space is something that I'm hoping, we can kind of move forward. And also because as long as we're limiting it to the fact that you need to use, those guide wires and biliary access devices to try and get the stent to where it needs to go, it's going to narrow the market of who's going to be comfortable doing it and in what settings and in what situations.
Yeah, all true. And that's the thing, again, a little bit of a digression, but there's so many parts of therapeutic endoscopy that continue to merge and blend, and you're 100% right. The world of EUS and ERCP merging, the world of ERCP and stent placement for luminal stricture. There is so much overlap, and it makes you wonder how that's going to continue to merge, because it has to, right? I mean, it will. Um, but there's so many aspects that overlap. And one thing I often wondered from the perspective of technology and new devices is, do we start to see more kit-based devices? Like you mentioned, like managing a big fistula or a big perforation, where you may want to use some sort of endovac therapy in addition to a covered self-expandable stent. Does that get put into like a fistula repair kit or something? You know what I mean? Like whether, it almost makes you feel like that kind of has to be the way we go, because right now we're using so many things just randomly piecemeal, grabbing them off the shelf for an unintended indication in these cases. So I don't know. It's fun to think about what the future may hold for the things we do, and makes our job fun. With that, I would like to thank Julie Yang and Koushik Das for joining us on this ASG podcast from the Technology Committee. Certainly an outstanding document. It will be again in full publication in GIE in the coming months. I appreciate you guys for all your hard work on this document, and thanks for joining me today.
Thanks
Thank
for having
you.
us, Ryan.
All right.